I welcome everybody to our social justice research seminar. This is our second meeting of the seminar, and I am honored to be joined by one of our teaching faculty, Dr. Tracie Kirkland, who is beaming in from Texas, which is very exciting. You know, the glory of Zoom allowing us to have even our faculty who work remote to be our presenters, not just our participants. And we have a number of folks online, I see, which is fabulous. And I will say we have, I think, 1 week, November 26th, which is the week of the Thanksgiving recess. That's the only week this semester that we do not have a speaker lined up. So we've got some pretty cool stuff coming in the next several weeks we've got one other nursing faculty who's going to be presenting, and we have a number of tenure track colleagues who are going to be presenting. I've been doing some more outreach to PhD students and also other folks outside of the tenure track line, hoping to get lots of engagement in scholarship from across the university. So with that somewhat rambling beginning, I will just say one last thing about the format of this, which is that this is meant to be an informal sharing and conversation. And so Dr. Kirkland will be sharing with us for about 20 minutes her research on building connections, addressing social justice and food insecurity, which is, at least for me and my academic interest, sounds absolutely fascinating. And then she will host about 15 or so, 20 to 15 minutes, depending on how timing goes, of questions and discussion afterwards. I guess we have these ceiling mics, so you got to kind of pretend that you're me and project your voice a little bit if you're going to be heard over here. And we will definitely love to have folks who are online. I see that we've got probably half of our audience this week is online like it was last week. So please don't hesitate to use your raise hand function or throw your question into the chat, whatever you're most comfortable with. If you're a chat user, I'll read the questions with my projecting voice. I was never in theater, but I still know how to be loud. Okay, I did work in a kitchen for a while. All right, so Dr. Kirkland, take it away.
Okay, greetings. Can you hear me okay?
You sound great.
Okay, great. Thank you for having me. And for disclosure, you see Nelda C. Stark College of Nursing because this was my PhD dissertation that was conducted at Texas Women's University, where I actually examined social support, loneliness, and food insecurity in Black women, 45 to 85 years of age, just examining the intersectionality between those three variables. For this particular talk, however, I changed the title, and it's entitled Building Connections Addressing Social Justice and Food Insecurity, which to me is very timely in today's society with everything that's going on. So I'm just going to spend a few minutes with you and just share with you my passion, what's evolved over the last few years, and what is still evolving as I speak. I met with my statistician on yesterday, and hopefully we will be submitting our second manuscript by the end of this month. So I'm using beautiful AI, and I'm hoping that technology is going to work today. So we would be remiss if I didn't share objectives. There are 3 objectives that I would like my participants or the audience to leave with, and that's to define key concepts related to social justice, food insecurity, and social support. Explain the impact of food insecurity on individual and community well-being, and describe the relationship between social support networks and loneliness. So I really should have stated at the end of this presentation, because I have a student here and I want that student to know that it should be at the end of this presentation, learners will be able to define the key concepts, to be able to explain the impact of food insecurity, and to also describe the relationship between social support networks and loneliness. So as we turn the page, when we think about food and social justice, and we think about Maslow hierarchy, we think about the human right. Food is a human right. Every individual should have access to food. And when we combine food and social justice, and we look at human rights, we as a community, as a society, as healthcare providers, as workers, and as community members should be doing our part to ensure that every individual, family, and community member have access to food. So what do we do and how can we do it? Those are some of the things that we will talk about today. In my particular study, there were 3 different variables that I examined. I examined food insecurity as it was linked to loneliness. And there was an article back in 2020 that examined similar variables. I also examined social support. There are lots of different support systems. And I, in particular, examined instrumental and emotional support. And in the literature, we found that when compared to white women, Black women are more likely to have low or moderately low levels of support. And that's according to Ash and LePain in 2018. I also examined age. I postulated that, or I hypothesized that older Black women would be more food secure compared to the younger women that I enrolled in my study. So stay tuned and you'll hear the findings when I report out. It really was an inverse relationship. So COVID, when we talk about social systems and social factors, food insecurity has been around for a number of years. It's nothing new. However, during COVID-19, it illuminated the problem. And this is just an estimate here that approximately, almost 4 years ago, actually 4 years ago, the evolution of COVID, hence we had a higher incidence of food insecurity. And during my initial study, my study was to really focus on food insecurity during COVID-19. The feedback that I received is that COVID-19 was at the downside. We were at the very tail end. So my dissertation committee, my committee members, and some of the individuals, when I reported out, they really questioned whether or not my data that was collected occurred during COVID. Well, as a healthcare provider, I can tell you last week in clinic, I still diagnosed COVID. We are still in an era of COVID. So the question is whether or not the incidence of COVID increased food insecurity, whether or not that prevalence has remained, or whether or not we've seen changes. And that information is still forthcoming because, as we know, post-COVID, food insecurity has increased in its incidence or prevalence. So food insecurity, what is it? It's a complex construct. And if you look in the literature, there are various definitions of it. Here are a few. And Anderson in 1990 defined it as food insecurity exists whenever the availability of nutritionally adequate and safe foods or the ability to acquire acceptable foods in socially acceptable ways is limited or uncertain. Morello et al. In 2017 stated that lack of access or availability to healthy foods due to scarce resources or money. And as we talk about social systems, that's important because we're thinking about climate change that's affecting food access. We're thinking about the procurement of food. We're thinking about transportation systems. We're thinking about global warming and all the different contributors that are now affecting the production of food and accessibility of food. And also we're thinking about the food deserts that are occurring in many of the communities. It's also defined as lack of availability of healthy food and also limited access to a sufficient quantity of affordable, nutritious food. Okay, the significance. In my particular study, I found that 59% of individuals were considered to be food insecure, and they also had low social support systems. Additionally, 31% of individuals were found to have low food insecure and low social support. In the literature, food insecurity, there's a high prevalence in Black women and in Hispanic women. And that's basically because they serve as head of households. So as a result, because it's relatable and was of interest to me, I examined Black women. My dissertation chair advised me against examining Hispanic women because it would require me to have a translator and some other additional factors that probably would have prolonged my graduation time, and we were not trying to do that. So that was a limitation, but that is an area of interest as well. So the literature review, here's my search strategy, my key terms that were used. And this picture or this slide is just to depict that food insecurity is really a problem. Social support and loneliness are additional variables that are of concern. Since I completed my study, the president deemed loneliness a public health issue, not only within the United States, but it has been deemed a crisis globally as well. So what can we do about that as healthcare providers and social workers interlocking, collaborating, and making a difference with the aim of reducing food insecurity, decreasing loneliness, and impacting overall health outcomes? So this is just pictures just to create pause for my visual learners. The purpose was to determine the relationship between social support, emotional and instrumental support, and loneliness in Black women. And again, it was during COVID-19 in my lens. Why? There was a gap in the literature. So in the literature, if you review, there's information on Hispanic men and women, Hispanic women and Black women, but not specifically women between the ages of 45 to 85. 85 was the cutoff because nationally, in terms of older adults, 85 in terms of resources, that was the age that was delineated in the literature. Hence the reason I cut the study off in terms of 80 individuals that were age 85. My research questions were, is social support emotional and instrumental, loneliness, or age significantly related to food insecurity among a sample of Black women? And if so, how? My second research question was, is social support emotional and instrumental, loneliness, or age a significant predictor of food insecurity among a sample of Black women? And if so, how? Two different questions, relational and then as a predictor. So here, this is just to depict my independent variables and my dependent variable. Again, it was just a schematic that I used when I was sharing. My theoretical model was that of the Newman model. It's a nursing model that examined primary, secondary, and tertiary prevention strategies. And it was very appropriate because as I delve further and I examine my intervention, it will provide a basis for me in making recommendations for policy, for making recommendations for screening, and hopefully for creating collaborative teams in addressing social support, loneliness, and food insecurity. So this is just a depiction and it's used with permission from the actual author. The methodology, So it's a descriptive cross-sectional. It was a descriptive cross-sectional study. And I recruited from churches or faith-based organizations and community centers within the greater Third Ward of Houston. So I was intentional because within the greater Third Ward of Houston, it's a historical area where Blacks reside, and it would also allow me to create relationships with the churches, with the grocery stores, with public housing, and to really have a good sample of individuals that I was looking to recruit for my study. And I was not a helicopter and landed. And oftentimes as researchers, when we're going into community for community participatory research, relationships are important. And because there was a simulation or assimilation, and I was a Black female, it was not the understanding that I could land and I could recruit. For a full year, I was intentional and I established relationships. I attended food banks, I attended churches, I went to public housing. So when it was time for me to recruit, individuals knew me and they were able to use a snowball effect and share information, and individuals trusted me and thereby enrolled in the study. And those are really important facts to consider when you're recruiting. So again, my population, Black women, the age, my sample size was N equal 85. I did a power analysis. I needed 71 for enrollment. I was able to recruit 87. Two were dropped because of incomplete information. And my tools, I'm sorry, this is new technology, and I have to go back and work on my timer. That's some feedback that I'll take away. But the tools that we use, I was brave. I used two tools. I used two instruments that were valid and reliable. I used the HSFM food insecurity tool. It has modifications. You have a long version, a short version, and I used a brand new instrument by Johnson. Johnson's food insecurity tool allowed me to examine the quality of food. It allowed me to examine the social factors, and it provided me additional data that the USDA food insecurity tool does not provide. So that's the limitation. And as I've read in the literature, that is a big limitation in terms of the ability to acquiesce information on culture and social factors, which may be influences on food insecurity. So to date, I think I may be the second person who have used the Johnson food domain tool, and we're very excited to be able to publish it because we're trying to pioneer and actually help add to the validity and reliability of that particular tool instrument. So I obtained appropriate approval from TWU, from faith-based church, faith-based sites, and I was able to read my questionnaire to participants who needed me to read aloud to them. They were able to read out loud for themselves. So there was an ability to meet individuals who may have had low literacy levels. Okay, so here is the format. We had hard copies. I did not use any technical equipment because the research showed older individuals, and especially in certain ethnic groups, may have difficulty in navigating. So I elected to do hard copies. And again, I read these to those who needed, and those who didn't, they answered the questions right then and there at the point of administration. So here are my tools or instruments. I use the NIH Adult Social Relationship Scale. I did not use the UCLA Loneliness Scale, which is probably the most commonly used tool when you're examining loneliness. I selected the NIH Adult Social Relationship Scale because it allowed me to examine emotional support, instrumental support, and loneliness. It came with a fee, but when you entered the information, it actually populated and did the scoring for me. And it's a valid and reliable tool. And I have the Cronbach scores, I have everything in my paper that illustrated that. My demographic questionnaire asked about age. It inquired about individuals living in the home. Did you receive any type of federal assistance? We inquired about annual income, transportation, because as we're examining social determinants of health, it's really important to understand it affects where you live, where you're born, where you work, and where you play. And it can affect transportation, access to health care, food insecurity. You can have economic, educational. There are different types of discriminants for social determinants of health. We also inquired about income. And as you may suspect, the majority of the individuals were below the poverty line. Females, again, were the head of household. Many of them, I'm going to show you here, many of the majority had never married. So again, when we think about food insecurity and the prevalence rate, many of them were single women who had never married. 36% were married at some point, and then you had some who answered as having significant others and others who were divorced. So if I go back in terms of the descriptives, 47% were under the age of 50, so between 45 to 50. Another percent was we classified as senior and non-senior. So 47% were considered seniors and 39% were non-seniors. And the age, again, we did like maybe 45 to 60 or 65 for non-seniors, or 60 for non-seniors and 65 and above as seniors. And we had information or data to help us to categorize into our dichotomous senior versus non-senior categories. The majority had chronic diseases. Only 12% identified as having no chronic disease. 60% received government assistance. However, I was not specific. So we don't know the specific type of government assistance. It was just yes or no. Do you receive it? And then 21% stated that they didn't receive it, government assistance. Okay. So I'll just give you a couple more before I end. Employment, 49% were retired. 26% were unemployed. 10% were still working. 13% were working part-time, and then 1% had been laid off secondary to COVID. So that's just some descriptives. Again, here's some information on the educational. 32% had some college or post-college, 15% technical. So that, let's go back to the college. So that means that even our educated patients or participants or community members, it did not matter, at some point identified as being food insecure. Even a retired nurse that I talked to was had suffered or acknowledged being food insecure. I would like to also state that as participants were completing their questionnaire, they would look up and would be embarrassed because one of the questions would ask, have you, within the past 30 days, have you had to eat molded food? Molded or rotten food. So just imagine having to answer that question. Another question was, within the 30 days, have you run out of food And if so, at what point? And it's usually around what? The 20th day, like right after the middle of the month. So that's the period in which the participants would utilize food pantries, or would be probably eating what was left over or not eating at all to make sure other individuals within their homes were eating. So even as we had 65 to 85 individuals who were 65 to 85, they still would have young children in some instances because they were grandparents and they were serving as caregivers. So it's just illuminating, and it's just demonstrating the prevalence of the social factors that are occurring secondary to food insecurity. Okay, so this, I have information about housing, 24% owned, the remainder rent or leased. And my results, this is probably the important part here. So according to the USDA instrument that I use, the only thing that was a predictor or demonstrated correlation was age. And it was an inverse relationship. So where I hypothesized that older individuals would be food insecure, it was actually younger individuals. And when I delved in the literature to help support that in my discussion piece, there was an article in a study conducted in Canada that stated older individuals generally have what? They have their retirement, they have resources that they have they've qualified for, and our younger individuals tend not to have retirement benefits. They tend to still rely on federal subsidies. However, the gap is we need to do a better job with screening within that age group. And not only screening to see if they were food insecure, but also when they identified as being food insecure to link them to services. So that's the social support portion that we can do as a group collectively, is to encourage our nursing students, our healthcare providers, our social workers to use the food hunger vital sign and screen, but not only screen, but when they screen and it's yes, have resources, food pantries, WIC, if it's younger individuals who are who meet the criteria for WIC, and or to help plant gardens within localities and help, and or write policies where we're providing grocery stores in these particular areas. So I'm going to stop there. That's a lot of information in 20 minutes, but hopefully I've painted the picture and given you some of the small nuggets and how it's going to evolve, and how hopefully from this, someone will be interested in helping me to devise a research team where we can collectively make a difference. So thank you.
Well, that's great. This is a wonderful presentation, Dr. Kirkland. So we have at least about 10 to 15 minutes for conversation and questions. Are there any questions? Maybe I'll turn to the online audience first, because last week I think I turned to the room first. Are there any questions from folks online? I see one.
Hello. I apologize. There's hold music going on in the background as I'm trying to help a patient. My name is Karen Lindsay. So I'm actually a doctoral student here at USC in social work. And thank you so much for this presentation, because that's truly kind of the core of the work that I'm doing. And I know that you are doing as well, is really this interrelated relationship between mental, social, and physical health. What was of course, very interesting to me, being as someone that's working in healthcare, because I agree that there is this need to provide that education to healthcare providers, which I think we're now starting to do. And that's the biggest issue is, as you said, and then to have resource linkage. It seems like, and some of this is just kind of anecdotally from my experience, is that the indirect sort of resource linkage. So thinking about things like food pantry lists, or, here's a phone number for Meals on Wheels, give them a call, tends to kind of have a lot of these really big delays. I'm wondering kind of what your thoughts are and how we can change the way that we approach healthcare, or have those things more available in a more direct way, whether they're direct referral pathways, or here's a prescription for our food pantry down the hall, or kind of what those things could look like.
Thank you for that question. A combination of all of those things and really being intentional. So two things. I'm on a health equity task force here in Houston. And by the way, I think I wrote down that we have approximately 4.6 million Texans who are food insecure. And that's inclusive of 18 counties here. Houston is large. Houston and LA, I think, go between number 2 for LA, and Houston is number 4 in terms of the largest city. One of the things that the health department is doing, or the community health agencies are doing, is food is medicine. They have a food is medicine program. Dr. Sharma is probably a leading, renowned researcher in the area. If you put in food is medicine in your Google, your engine-based search, her name will populate. So that's one of the things that they're doing. They're identifying individuals who are in the hospital or in healthcare systems who have diabetes, hypertension, maybe gestational diabetes as well, or chronic diseases. And they're doing a food prescription where they have access to fresh produce. They'll have access to different foods to help to align with their chronic disease. So that's something that is emerging. And in order for programs like that to be successful, it will require us to advocate, to amplify our voices, and to create policies, to have funding to support and make these programs sustainable. During COVID, there was an increase in aid if you met certain criteria. You had extended benefits in terms of financial resources and increased access to purchasing foods, but it ended post-COVID. But people are still hungry. So partnering with groups like Cisco, PepsiCo, and other corporations also to make a difference. There's global presence. PepsiCo has a global presence. Cisco actually during the COVID-19, they did food banks, but it's really partnering with these corporations to make a difference. Amazon has a program. I think I reached out to Eric or maybe the dean to say, hey, Amazon has a food program. They have resources. They have grant funding. They have money for grants for individuals who can demonstrate through proposals that you want to pilot things. So there are ways in which we can do it, but it takes a collective body to be able to do this and to do a lot of pilot programs as well. So thank you. Did I answer that question for you?
Oh, yes. No, thank you.
Okay.
Go ahead and take another one from the Zoom audience, then we'll take one from the room maybe. I think Michal has her hand raised first.
Yeah, thank you. And thank you very much for the presentation. It was very thoughtful and interesting, captivating. What I find shocking and continue to find shocking is that we live in the richest country in the world, and we have people who are hungry and food insecure. And even when they have food, it's not good quality. And your connection between food and medicine, we know it. We know it. And people are sick because of the quality of the food, even if they have it. So my question to you actually is something else. I'm asking what you found. Was there one thing that you found that was most surprising to you in the study?
I think the most surprising It was, well, actually, it was two. It was actually, number one, it was the stigma, and that people literally were eating rotten food or molded food. And again, you saw the percentage. Some of these were educated individuals. We don't know the circumstances because we didn't do a deeper, it wasn't a qualitative portion to the study, but that was, to me, was really interesting, to the point that that's my part B of my research study, is to now go back and do a qualitative portion. The other thing that was really surprising was the age. We really thought that older individuals would be lonely. We thought that they would be have more increased risk for food insecurity. But again, this was with my USDA HSFM tool. My 4 food domain is showing totally different. We just analyzed the data. So stay tuned for a part 2 for that. So, but the age was what was really, it was really interesting to me.
Thank you.
Yeah, thank you. In the room, go ahead.
Oh, hi. Hi, Dr. Kirkland. Great presentation, by the way. And from personal experience, during COVID, I used to volunteer at OC Food Bank, and do have this lived experience where I move food boxes around. Like you said, it's the 3/4 through the months, and then distribute to older adults within the area. And then I do know that's a huge problem. But so yeah, in terms of it's the research itself. When you're talking about the definition of food insecurity, you talk about, so there's basically 2 camps. Of one's more on lack of access, one is more on the side of lack of availability, and both factors can be resolved by simply economic factors.
Yes.
I think that could be the reason why that when the older adults are actually less likely to experience that, the younger adults more likely to experience that because of the lack of income.
Absolutely.
So
yes.
If that's the case, does social support still play a part? Because economic eating so much variance within that circumstances. What do you think about that?
So it's really interesting when you go back into the literature, by just in theory alone, Black families have a strong network, a strong social support. So culturally, by I should have said that. I was really interesting too. I don't know why I didn't just think about that, but initially when I was thinking about my variables, but the social support it's there. So even when you have instrumental people dropping off food or people stopping by, the emotional part, they had faith. So that could be another part. Their faith, they would stop and say, when they are answering the question on social support or emotional support, many of them were religious, and their faith was their guiding or their North Star or their guiding light. So basically, they had strong support systems according to this particular tool. But as we're looking at the other instrument, we're finding some variations. The emotional support is correlating, but still the instrumental support is low. So there are different types of support systems, and we need to delve a little bit deeper and have a little bit clearer vision as we're writing up the discussion portion. Did that answer your question?
Yeah, that does.
Okay.
That's great. Thanks. Another question in the room? Go ahead.
So I was just going to piggyback off of that and ask if you think the matriarch of the Black family and that playing a role, as well as we're kind of talking about economics versus cultural impact, and then maybe the older. Anyway, I would just be interested to see would that look different in a Caucasian population or in a Latinx population or something like that, because correct me if I'm wrong, but I do think that the Black community, Black families, the matriarch is the older female is just so well
Absolutely.
supported by the family. And I wonder what your thoughts are on that.
You're absolute. Thank you. And thank you for being here to support me. Yes, the answer is yes, in the Black community and in the Latinx community as well. And there are some studies that that demonstrate it and illustrate it or confirm that. But what happens as a result of that being that matriarch or strong or that superwoman, there's an increase in allostatic load. And that increase in allostatic load increases their risk for chronic diseases, diabetes, hypertension, the comorbidities that are associated with all of those. So that is why one of the, when I submitted my initial manuscript, the feedback was to expand upon the chronic diseases and the relationship to food insecurity. So it's, I mean, it's so much you can do with this. I mean, with this particular study and the ability to create future research teams to address it. So you're absolutely right, Shelley. The matriarch of the family is generally the Black female. They've worked all of their lives. They've supported their families. They would eat. I mean, their children or other extended family members would eat when they would not eat themselves. So thank you for that question. Or observation.
All right, well, I think we've got one more online. Miss Evangelista, I feel like I'm going to butcher your name if I try to pronounce it.
That's okay. I'm Jason. Yeah, I just want to first say, Dr. Kirkland, your presentation really, really touched me. It was very informational, but it was also very like impactful emotionally, and I think a lot of people can agree on that. I also want to extend a lot of pride in all the colleagues asking amazing questions, because I had the same exact questions, and I just also wanted to kind of piggyback off of what other people were saying about these like different types of demographics, different types of intersecting identities coming together, and how that would impact or affect in any way how your research is, what your research was on. Specifically though, I was really interested in different like identities of these of the people that you're studying, and how that would also affect the results. So for example, people who may have identified as a different gender, people who might have identified with a different sexual preference, those of different religions, and then also kind of what your thoughts are with urbanization versus like rural populations, focusing on poverty and focusing on homelessness and food insecurity in that way.
So stay tuned. That's under my future recommendation or future studies to examine those variables. And if you're a PhD student, your chair is probably advising you to keep it, to limit your variables. You want to graduate, and then upon graduation, you can expand and you can do others. I specifically chose Black women and the age and the gender in terms of Black women, and then Black because of personal interests, and because that the area that I was actually interested in, I reviewed census tract data. That was my guide. So I did like a pre-assessment to allow that to be my guide, to be able to answer questions like this in my study with post my PhD presentation when they asked why. So based on that information, that census tract data, that's what led me specifically to that specific population. So that is my future research. Now, in terms of, you were asking about other, from an urbanization perspective, well, really to understand food insecurity is to understand structural racism, which dates back over 400 years ago, and really understanding the inequities in income, the social constructs and barriers that we as a people have suffered. So all of those, couple all of those, and fast forward, we're still in the same predicament in terms of the inequities, in terms of income, in terms of housing, in terms of access to things. So again, from an urbanization perspective, we need more grocery stores. In that particular community, they had just removed the H-E-B or the Kroger from that store. So you have 5 and dime stores, or you have a little the marketplaces, which really have a lot of processed food and canned food. So the urbanization is needed, but income, revenue, jobs, and federal policies are needed to really address the larger issue, which is structural racism.
Well, that's actually such a great note to end your question and answers on big issues. I want to be mindful of folks' time, so I want to just give another thanks and round of applause to Dr. Kirkland.
Thank you for attending.
Sorry
for my technology.
Yeah, no, your technology was fine. I think, stay tuned next week. I think we have Dr. Castro, who's going to be talking about moral injury. And if you want to stick around in the room and have conversation, or if you want to, I'll leave my Zoom room open for a couple more minutes if folks want to ask you, but I also want to be mindful that people may need to leave. And so I wanted to just thank you one more time. It was such an inspiring talk. And as one tiny little thing I'll just add to it, for those of you who are students in the space, sometimes people think they have to have gigantic data sets to write something that's really impactful. And I just want to point out how great, if you have a really important question and you're really thoughtful about how you're approaching doing community-driven work, even small research projects like this can be terribly impactful. And I certainly did a lot of things like that when I was early in my career. And it's great to see folks doing such impactful work. And so Dr. Kirkland, congratulations on such great work. So thanks, everyone. All right. Thanks for coming, folks. It's nice to have an in-person. Thanks for coming. It's nice.
Saw your hand, Kelly Marie.
Hi. You have no idea. I'm in the MSW program, and I'm not a quote traditional young student. I'm 62. And
that's much better. Hey, Olivia, did you leave your keys on the chair? Olivia, did you leave your keys?
Is that there? Is he? Is it
I'm
Eric?
listening to you. Go ahead.
Okay. Okay. In the MSW program, early in the first couple of semesters, I had multiple people, including, from students to faculty, say, why aren't you doing something in food justice? And it all came down to that there was nothing at USC. So where I'm at right now is that I actually, I'll graduate in December, okay? Food justice is where my heart is. I am somebody who has done so many things in the whole realm of that. What I'm looking at, and maybe you can tell me a couple different things. One, I'm looking at starting a nonprofit. I live in a small town of 297 people in Merced County, okay? And we farm. And, I married a farmer. I grew up in the city, so this is all 36 years of accumulation. I'm trying to figure out the food bank in our area is not real super proactive in doing things. I love the fact that you said you're doing gardens. Nobody, that's, people started on their own, but there's a lot of things like that. Where do I figure out where to start? Do I start with a nonprofit? Is that a good way to start?
Let me give you my number, my email, and email me.
Oh, that would be great.
And I can tell you how, and again, a lot of it is partnering. So I'm very active in lots of organizations. And one of my sorority, the sorority that I'm in, they actually partner with schools and they build community gardens. So it's not like something that you have to take on. And you have Boy Scouts, Girl Scouts, other groups that would be interested. They're looking for projects. So again, finding the right group, community group that may be interested in partnering, or someone may already be doing it in a neighboring place that may carry over into your catchment area.
Yeah, see, and there's some, but I keep hitting a brick wall, and part of it is, and I say this only because where I live and what I know. I was born in Long Beach, California, and I grew up in Santa Rosa. And when I married my husband 36 years ago, they still in our area are still not doing recycling. Okay.
So I hear you. So from a rural perspective, here, let me give you my information.
Okay.
It's T here. I'll put it in the chat. Can you see the
Okay.
chat?
Okay. I just was super, and actually, Jessica Costello, she's my liaison between my internship and USC. And when this came up the other day, she tagged me with whoever else was the people that were putting this on because she wanted to make sure that I was able to come. So
Oh,
thank you.
absolutely. Yeah, I'm
Thank you.
happy
Thank
to
you. Thank you.
assist you. No problem.
Okay.
Hi,
Thanks.
Karen.
Hello. I didn't want to capitalize on time too much. Thank
That's
you for
okay.
staying for a few minutes because I also wanted to touch on your point related to stigma and underreporting and also purpose confusion, I think, for patients. If this is kind of part of their check-in process, why are you asking me these questions? Why would I be honest about them? And you know, how does that even relate to what I'm doing here in this clinical appointment? So I was wondering your thoughts on kind of how to tackle that in a healthcare setting
And yeah,
before
you know
screening
what?
happens during versus after, where then now it's already taken place.
And you know what? That's a great question. And I didn't fully share that I'm an adult and pediatric nurse practitioner. So I actually am seeing and doing this as well. So really integrating it into the system, into the EMR, and actually administering the questionnaire as a part of the check-in and making it a requirement, and you know, fully disclosing that this is confidential information, and most likely within the next year or so it's going to be mandatory because CMS is actually relating it to a part of their value-based care system, their metrics. It's going to be a part of their metrics. It is a part of their metrics as of a few months ago, I think a few months ago. So allowing it to occur where the individual can do it at check-in, okay? It's just like the PHQ-2 or PHQ-9 questionnaire for depression, and just making sure that that medical assistant or that point of entry, that point of contact, that initial point of contact has reviewed and that it has been filled out, and then the provider is prompted to review the response. I had a patient maybe 3 weeks ago who came in for another problem. I think they came in for just a wellness appointment. And I asked, I'm like, are there concerns about food? I say, you know, when you feel safe? And they were like, oh, sometimes, you know. So she told me more about that. We asked her any thoughts of harm to herself. She answered that question. I was like, any concerns about food insecurity? Do you have enough food within the last 30 days have you had enough food? And one of the questions was no. And she told me she used food pantries. It was already like I'm going to say the 20th of the month. I stopped clinic. I went out and we created a list for her. So I could I could formally give her, here are resources for you. I see that you have small children. Are you on WIC? Have you thought about applying for WIC? And oftentimes you can do the questionnaires over the phone for eligibility or even on your smartphone. So I went through that. So it requires intentionality. And I will tell you that there are probably, and I can say this, private practice is going to differ from an organization that's linked to an academic teaching hospital or that's within a larger system. Private practice, it has a different mode of thinking when they're seeing patients. So the social aspect may not be as high on their radar in terms of doing that. But collectively, we can make a difference by amplifying our voices and asking our colleagues to do these things.
No, I agree. I think that's the challenge, is that we have all these things embedded into the EMR. So I work in a large healthcare system. So I'm on the outpatient side. I'm actually in orthopedic surgery. So a lot of the focus that I have is on orthopedic trauma where, oh, I don't have all these social needs. Oh, wait, they develop in my recovery because I can't make food for myself or get it for myself because I can't bear weight on my left leg. And so I think that's because we've also seen it. I've been in this department for almost 5.5 years, and that that's what we see is like there's great screening that's happening that's built into being part of the check-in process, whether it's e-check-in from home or when patients are here. But I think the challenge is still, why are you asking me these questions? And why would I answer them honestly? And I think that's what I'm trying to, you know, kind of get a lot of different feedback about. How can we do that, especially for our e-check-in patients at home?
It's a culture change. And I'm currently in the Teaching for Excellence fellowship, and look up Kotter's change, KOTTER''S. And before you can implement change, people have to understand the first step, and that's the urgency. You know, what's the urgency of doing this? And it requires a culture change and buy-in by your internal and external stakeholders. And then the end is, how is this going to be relevant for me? Well, from CMS, it could be relevant because if it's a metric and you have 90% of your providers asking these questions, at the end of the year, you've demonstrated you've met your metric, and you're going to be incentivized from the federal government. It's just like your heart failure patient. If you keep them out of the hospital without a 30-day readmission, and you've demonstrated this and you have good outcomes, you're going to be incentivized. So it's looking at the steps of change, obtaining buy-in, and then how is it going to help the organization from a return on investment?
No, definitely. I think you bring up a good point where there's a lot of those pieces kind of swimming around and happening, but that some of this onus is on me to convey the urgency, and depending on the audience of kind of the what's in it for me and how can this be helpful. So
absolutely,
I'm working on that, but thank you.
You're welcome. Let me know if you have any questions.
Thank you. I so appreciate your time. Enjoy the rest of your day.
Okay, thank you.